My title of the presentation today is, if it is not my tooth, what is it? Okay, I think that if some of you have gone through that journey, I hope that this presentation will really help you out. Okay, so this is just a regular X-ray, and I just wanted to show you some stuff here. So this is a tooth that has nothing, right? So and this is where I'm marking here is the bone level, right? So what you see about that bone is what you see in the mouth, and what we don't see is the root, or what we don't see, obviously, when you open your mouth. When you see now in the roots, right, again, what is in the bone, right, and you see white stuff there, is because these teeth have root canals. And this doesn't look really like a root, right? It looks like more like a screw or something, and it's actually an implant. And then you will have the crown or the cap for that implant in the top. So this is just a regular X-ray. I wish, I forgot to say that hopefully, please do not take X-rays, pictures of my presentation. Some of the X-rays are from real patients. This one is from the internet though. So regarding toothaches, is if a tooth hurts, we have to be clear that 93 to 100% of the times it will be the tooth. But that very, very small percentage, up to 5 to 7%, it is not. And as a human beings, don't feel bad, as a human beings, how our brain works is that if the tooth is hurting, we will go to two main choices. We will just say, please remove the tooth or have a root canal, because if we have a root canal in the tooth, we should not have any pain because we will remove the nerve. And if we remove the tooth from our mouth, obviously, we should also not have any pain. However, sometimes people ends up like this, where every single tooth of the mouth, I already showed you, right? This is the bone here. So whatever is not in the bone, right? Inside the bone is the root. And when we have these white spots, right, are basically root canal. So this patient has, this is very faint here, but has a root canal in every single tooth, and where is no teeth, have it removed, right? So the issue is that the pain persists and continue being unbearable. And that's the problem. So the tooth hurts, we think it's the tooth, we remove the tooth, we do a root canal in the tooth, and the pain is still there. So what can we do about that? So if it is not the tooth, what it is, right? So if it is not the tooth, it could be a muscle pain. It could be a muscle. Dr. Friesen already show you some slides where the masseter, this muscle that is in the cheek, the temporalis, the muscle that is in the temple, or some here like an anterior digastric, can cause a toothache. So every single tooth of the mouth, it could be, when it's not the tooth, it could be from a muscle origin, right? It could be also a migraine. So for any of you suffering from migraine headaches, you can have a migraine toothaches. It could be another type of headaches. They're called trigeminal autonomic cephalgia because they have autonomic features. They have like this rhinorrhea, this tearing, this redness. And they're very, very uncommon, and having a toothache, trigeminal autonomic cephalgia toothache, is even more rare. I have never had one in my practice, but it's very well documented in research. It could be also nerve pain. It could be a neuropathy toothache, right? It could be sinus toothache, or it could be a systemic disease, nothing to do with the mouth. It's just in your body, like a heart attack or cancer. So what about when you have a root canal? So the first news that I want to give you is that you can still perhaps have pain after your root canal is completed, right? So this is a research conducted by Dr. Donald Nixdorf, who is actually Canadian. He's in Minnesota now, but he has his training in Alberta, personal friend of mine, very good researcher. And he conducted this study where he's found that people who had a root canal and there was still pain after 6 months of the root canal completed, and 37% of those people who had still pain was because of the tooth. So there was still problem with the tooth or the adjacent tooth. But 42% was another cause, not the tooth. And most of the time was TMJ issues. And by TMJ issues, I mean muscle or joints. Was one case that was actually nerve pain. 2%, like 11%, 2 cases were because of the tooth and also because of non-tooth issues. And 2 cases, by the time that he was able, assess these people, they were no longer having pain at that time. So another toothache, another study of Dr. Nixdorf, right, said that, well, those people who present pain, who have a still pain after 6 months of the completion of the root canal, they say that this pain will be mild to moderate intensity. It will be present about 10 days in the previous month, and it will not really interfere much in their daily routine, okay? Now, what was a predictor of having developing this high risk of persistent pain will be that the pain duration in the week preceding the root canal. So you have a lot of pain, like a long pain, like the pain was lasting very long in the week before, maybe you will have a higher risk of developing persistent pain. And what will be an excellent predictor that maybe this will not happen is your optimism, the optimism of the patient that I will have my root canal in the tooth, and when the root canal is completed, my pain will actually resolve. It will not be there. Okay, so words matters, and that is for attitude, positive thoughts, mindset matters. Okay. So if you have a toothache of odontogenic origin, well, Dr. Hernandez, how I will differentiate if it is really my tooth or it is not my tooth? Well, if it is your tooth, probably it will be when it begins to be, in the most worst moment, you will be a throbbing quality, it will be severe intensity, it will be worse at nighttime lying down because you're lying down. It's not because of night, it's because you lie down. Every time you lie down, it is a change in the proprioceptions of the proprioceptors, and that pain increase, right? It will be worse with temperature changes, cold or hot. It will be worse if you are trying to chew on it, with percussion. And assuming that now the tooth looks fine, so there's no clinical evidence of cavity, there's no X-ray evidence of any lesion, right? That pain, if it is odontogenic origin, it should be becoming unbearable in a week or two, and then the pain, you will have an abscess, or the pain will settle because the tooth died, right? When people say to me, I'm having this severe 8 out of 10 pain lasting for me for the last 10 months, I say, well, and what your dentist have said, well, my dentist said that my tooth is fine. We did a root canal, we have read that, and my pain persists. I can assure you it's not the tooth. A toothache will not be lasting forever without a particular change. So when we talk again about the different types, migraine toothaches, again, a migraine usually is a throbbing quality. So the toothache, when it is a migraine, it will be of a throbbing quality, what could also be a toothache, right? However, the pain is recurrent. So you will have a severe pain for a few days. You may feel even nauseated. You may be sensitive to light, to noise, and then boom, the pain completely resolved with no action, with no reason. The pain will be completely fine for a few weeks or for a few months, and the pain comes back with the same rationale. So it's that recurrent temporal pattern that will just say this tooth is a migraine toothache, and obviously you may have a history of migraine headaches. I have had, I think, 2 or 3 cases in my practice, and only one, the patient did not really have a clear history of migraine headaches, but the other 2, they did, and they could not believe it, but it was just a migraine. That's how it expressed in them. Again, we talk about muscle toothache a little bit in the beginning. This pain obviously will be present upon chewing, right? The people will have a history of clenching and grinding. The pain in the tooth intermittent, right? Again, when it is a toothache, assuming that the tooth is a problem, but you don't see any obvious cause, right? It will be mostly, I would say, provoked pain, and one is present and being spontaneous, it will not stop. But in this case, the pain will be very bad, and then you can be fine. And then the pain will be there again, you know. The tooth will be sensitive to heat and cold. You cannot chew on it. So that is typical also toothache, right? But the pain will wake you up at nighttime and will wake up maybe with pain in the jaw. In the morning, right, it will be worse pain, right? And then you will have there will be a history. I already have a root canal there, Dr. Hernandez, nothing helped. I thought initially, you see, I'm missing my last tooth or whatever, because I thought that was the issue. We'll remove the tooth, and now it's my next tooth, and now it's my next tooth. That when it's my next tooth, and my next tooth is a very bad news. Probably is not the tooth. And if I freeze the tooth, right, if I put local anesthetic, the tooth, you may still have pain. And if I freeze the muscle, maybe that pain will resolve. So here, this is a case, of a patient that has 3 root canals in a time lapse of probably 24 to 36 months. And then was referred to me because now the pain was in the eye tooth. That basically is this tooth here, but the dentist then realized that the tooth is absolutely sound, virgin, doesn't have a filling, doesn't have anything, and so says, well, maybe the tooth, the pain is something else. And when I saw the referral, saw the x-ray, I said, oh, well, you know what, this is just not, this is nerve pain. That's what I thought initially. But the patient was having generalized sensitivity. She could not chew, everything has to be lukewarm, nothing hot, nothing cold, cannot chew on that side. But then I'm also stressed because, she was having a stressful job, and she was having tight in finances, tight in timings. And then she was also grinding and clenching, and her muscles were all on fire. They were all so painful. And I said, why we don't begin just by the obvious? And we provide her with conservative treatment, as Dr. Friesen said, and very fair enough, within a couple of 2-3 months, the pain absolutely disappeared. She realized within 2-3 weeks that the pain was nothing to do with the tooth. She was convinced. We managed to change the issues, and she was a very happy person since then. Probably this has been for the last 10 years. So what about nerve pain? The trigeminal neuralgia, probably you have heard about this pain. It's a sharp, shooting, lancinating, zapping electrical pain that will last a few seconds to minutes. You have a trigger zone. So you touch that area, you touch the tooth, and you just go, I don't know, to heaven or to hell and come back because the pain is absolutely unbearable. People just get paralyzed. They cannot move, right? And the issue with this pain is that if I put that freezing, that local anesthetic, the pain will completely resolve. So the dentist and the patient says, bingo, right? We've solved the issue. That was the issue. We did a root canal. We do an extraction of the tooth because at that time, the patient is you are just like fed up, like, you know what? I don't want to spend any more money. I just want to have a life. Please remove that tooth. I want to have peace. And to add more confusion, guess what? The pain will go away. For how long? I don't know. It may go away for a few weeks, for a few months, sometimes year. But the pain will come back, and I may come back in the next tooth, and again in the next tooth. So trigeminal neuralgia, as in the last point I mentioned here, independent of all of the above, trigeminal neuralgia may remit on its own. So it may be present for a period of time, and then without no further action, no real cause, the pain will resolve, the pain will disappear. And so people feel that everything is fine. It's just, and sometimes it comes and just doesn't go away, right? And this type of pain, of the condition, is usually managed with medication. So what about neuropathy, right? So that is a little bit different than neuralgia. The neuropathy is more like a dull, sharp ache. It could be throbbing. It could be comes and goes, or could be continuous. It could be mild. It could be moderate. It could be severe. It could be mild to severe. But the key to differentiate with toothaches, with a real toothache, is that really chewing on that side or having a good coffee or having an ice cream, it will not really change the pain. It hurts all the time. It doesn't matter, I understand, but it's aggravated by those actions. And when people say, no, it's not really, it will not be aggravated, that for me makes me think that it's not real, the tooth, because it will be the tooth you will have then more pain with that. And if I freeze that tooth, it could be equivocal. It could be that you have complete relief. It could be that you don't have relief. It could be that you have some relief. So it's a bit tricky. It takes a little bit more effort and diagnostic skills and experience and everything to put everything into a context to know if it is the tooth or not. It could be also systemic. It could be a heart attack, and so if it is your heart, the issue, right, it could be aggravated by exertion. Should you, when I was doing that lifting of heavy loads, my teeth in the bottom, usually at the mandibular teeth, in the bottom jaw, right, more in the left side, they're really hurting. And how is that pain? It will be usually throbbing and burning, right? And you will have probably a history of heart issues. That is very well documented. This extensive research, probably 60, 70 cases by wonderful research from a colleague in Latin America. However, I have not had one case in my practice. Cancer, yes, I have had a few cases. The history does not add up. It's a mismatch in the presentation. People are all over the place. Not that they are not giving me the right information. They are giving me the right and the truthful information, but it just the information that they're giving doesn't make sense for me to be able to reach a diagnosis. And it's very sad situations, obviously. So this is a case where did not really have, but she says it's my gum, right? It's my gum, my tooth. It's just getting inflamed. I cannot chew on that, and then my gum recedes, and my gums come back. The patient was almost 90, right? So this is just to again try to give you some hints. This is a regular jaw. I have a outline here, in pink, right? How it is the regular anatomy. And then I have also put a diagram about, again, showing the same in the right context of the cranium, right? And so in this case, actually, in the left side, right, you are missing all here. So it should be somewhere here, right? And all these are missing. Very, very strong. So I want to tell you two things about this case. One is that we say how much pain. She had pain, but not significant pain, maybe a moderate pain. How much function? She was able to open almost normal. Dr. Friesen says, 40, 4 centimeters. She was opening 38. There was a mild swelling in the cheek, so I thought that was the tooth. But the X-ray was absolutely stunning. Like you cannot, how can I say, deny that. And when we look in the mouth, that gum that was inflamed, not inflamed, was like this, and this is not an inflamed gum. This is basically a tumor. It's a lesion of the cancer. She had a history of multiple myeloma for 4 years. And in her fairness to her oncologist, the number were off for a while, but the numbers were completely back to normal in the last week or so. So it's not simple. And then this gum developed very quickly, like a lesion, like within a month. I think that she noticed, or she noticed that issue, right? So things are not simple. But so what about now if the teeth are not if the teeth, the mouth will give us the response. So this is a patient where he was obviously, you know, as many probably don't like the dentist, hate to go to the dentist, afraid of the dentistry, and then severe was having treatment, right? And then he was having pain in the left side, pain upon chewing, pain in the temple, pain in the jaw, right? Exactly what Dr. Friesen was discussing, and was referred to me because of a TMJ issue. And then when I went to touch him, he did not even realize he has a huge swelling underneath the jaw here in the submandibular area, like in the neck area. And actually, maybe you will be tempted. This is the first, the second, and the third. So this is the wisdom tooth. And you say, oh, was the wisdom tooth and not? Was this tooth that had a big cavity? And my colleague really tried to fix the tooth, but it was still too deep. And you know, the patient did not have a clue. The patient never had pain in the tooth, had pain in the jaw, right? And what about this other case? So this other case was a girl, 15 months in the medical system, all kind of tests, horrible. She was sent to me for TMJ because of headaches. And when she was talking to me, again, she was having seen allergies. She had 2 surgeries for the nose because could not breathe. The eye was tearing. She had her wisdom teeth removed. You name it. And when I saw the mouth, you can see this very redness, you know, like give us the idea of strawberry. And actually, this is called strawberry gingivitis. And you can see that it's plaque here. So she was, you can say there was not a very good brushing, but the brushing of the teeth is not because, you know, she was lazy, just because she was in so much pain, she could not take it. The headaches were killing her. And this is a very rare condition called granulomatosis with polyangiitis, or Wegener disease, is present in 1 in a million. And I was just maybe the lucky dentist that when she came, I did not know what it was this, but I really talked to a colleague, again, that multidisciplinary care, and basically I diagnosed her like I give her the diagnosis in within. She came on a Friday, and by Sunday we knew that this was happening, and I referred her urgently back to the medical system, telling the rheumatologist in this case to manage this condition. So some very personal takeaways, you know, there is no correlation between pain severity and anatomy abnormality. You could see, I showed you the case of cancer, the person could almost open the mouth normal, the pain was just mild to moderate, she was just unable to chew, that was the issue, right? The source of the pain may be completely different than the site of the pain. Again, it's the muscle, and you can feel the tooth, and sometimes, you know, the mouth, you know, you have the gums, and actually it's an immune condition in your body, right? If you experience a toothache, please, it will likely be the tooth. Only a very small percentage, 3, 5, maybe 7% of the time, it is not your tooth. They're dentists, you know, where they're oral medicine and pathology specialists like Dr. Friesen, or board certified neurofacial pain like Dr. Inas and myself and many others, or a few others, with additional and specific training to deal with these complaints. You know, when the cause is not obvious, then the diagnosis may not be immediate. It may take a few consultations among practitioners to reach a definite diagnosis. In the meantime, try to take notes, to pay attention. What makes it worse? What makes it better? How's the quality of my pain? How severe is my pain? Wakes me up at night? Is there any time of the day that is worse? What medications am I taking on? What dosages? If you have a long list, just bring the phone pharmacy, the fax pharmacy. We can send a quick fax and have those medications. People sometimes they say, I'm taking a medication for my kidney. I'm taking a medication for my gut. And I had patients when they took those medications that are not for real pain, but somehow they may have already an effect in your condition of your mouth. And then when you stop those medications, then things in your mouth flare up. So it is important to have that. Sometimes redoing a root canal or extracting that tooth, it will not translate in pain resolution, and it actually may aggravate your pain. Finally, your pain is real. I think that part of my sometimes experience that people are afraid or speaking up or telling me the things because they are afraid to be judged, they're afraid to be stigmatized, they're afraid that I will not believe them. And I particularly kind of like, I really care. I don't care what you like. You have to tell me the truth is the only way that I can help you. So your pain is real. I always believe that your pain is real. It is real, and I will try to help you as best as I can. And along those same lines, find a practitioner that you can relate, that you can trust. If you do not trust your practitioner, this will not get far. Like, you will not be able to reach a definite diagnosis. So I hope that I give you some tips, some ideas, some information that it will be able to help you out. Thank you so much.